Gary Frank. Gary has been a palliative care nurse consultant and resource nurse at the University of Alberta and Royal Alexander Hospital for the past 20 years. Prior to that, Gary worked as a hospice manager, community palliative care consultant, bedside nurse, psychiatric nurse, and special education teacher over the first 20 years of his career. He has served on the Clinical Ethics Committee at both the University of Alberta Hospital and the Royal Alexander Hospital. While Gary retired from his full-time nursing position in July 2023, he continues to work casual as a palliative care nurse consultant at the University of Alberta Hospital and Royal Alexander Hospital. Without further ado, I pass it on to you, Gary. Thank you again for being here.
Thanks, Michael, and thanks to everyone joining in today. It's a real privilege and pleasure to talk about my profession and to reflect on it in terms of ethical implications and just as the title says today, what is good care? The objective is simply to get us to think about what good palliative care is in order to help us to deliver it, hopefully. If you happen to have caught one of my ethics talks for the Dossiter Health Ethics Center in the past, you may have noted that I kind of take the opportunity when speaking for an ethics center to indulge in philosophical reflection. And some people like that. Some people don't really find it that relevant. I do a bit of that today, again, particularly because I feel definition of terms is important for having a clear discussion. But if that doesn't really appeal to you a lot, hang in there, please, because there's a case I'd like to review, a case study, and hopefully get your input on at the end during the question period. Speaking of definitions, there's many definitions out there of palliative care. I'll just go with the most recent World Health Organization website definition. Palliative care is an approach that improves the quality of life of patients, adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Addressing suffering involves taking care of issues beyond physical symptoms. Palliative care uses a team approach to support patients and their caregivers. This includes addressing practical needs and providing bereavement counseling. It offers a support system to help patients live as actively as possible until death. So I think that's an excellent definition. And those of us working in palliative care hopefully do the things that are described in there. On the other hand, there are situations where what the right thing to do is not always that clear. And that's what I want to look at today with you. Why did I use this term mystique at the beginning? It's because I like the ambiguity of it. It's as the definition here from Merriam-Webster dictionary suggests, it's got this air of mystery, an air or attitude of mystery and reverence developing around something or someone. It also implies possibly having an esoteric skill set for your calling or vocation. But the thing is, it's a double-edged sword, this mystique, this mystery, in that it can result in a lot of presumption and unquestioned generalizations. And a good example of analysis of this idea of a mystique and its ambiguity and its downside is in this classic of early, well, 20th century feminist literature, The Feminine Mystique, where Betty Friedan really looks at how this idea of femininity has definitely limited people in the past, a particular stereotype of it. In any case, so what I'm trying to do is move beyond stereotypes of palliative care today, I guess is why I put the word mystique in the title. And speaking of stereotypes, here are some. For example, only palliative care and spiritual care specialists can hold patients' hands. that's a little tongue-in-cheek, but I've actually encountered that on the wards where people say this patient needs their hand hold. Please call palliative care. Their handheld. Please call palliative care. I was actually beside someone once who didn't realize I was there or with palliative care, and said that, and it was quite humorous. Also, this is a self-perpetuated image, and there's nothing wrong with it, of course. Holding hands of patients at an appropriate moment is a great and supportive thing to do if they appreciate that, if they want that. But anyway, in terms of stereotypes, if you Google palliative care and go to images, you will find the vast majority of the images have hands being held, which is nice. Only palliative specialists should talk about end-of-life issues with their patients. Not true. Palliative care and life prolongation cannot coexist. Not true. Palliative care is symptom management, period. Not true. We need to remember that that's not true. Palliative care specialists should accept at face value the palliative nature of all referrals they receive. In fact, it's quite important for us to understand the assessment of the specialists involved for the particular disease in question, and understand their assessment of the situation being palliative and what that means for them, which leads back to why it's important for others other than simply palliative care to talk about end-of-life issues, because patients deserve to hear an assessment of their disease from the specialist in their disease. All right. There's more on this on the Government of Canada website, which has some good stuff on palliative care. So I just put some screenshots of that website up there. I think we need to probably give the group Pallium credit for getting palliative care featured, at least to some extent, on the Government of Canada website. And if you're looking at standards for Canada, this framework on palliative care in Canada is a good place to go. And that does tell us something about what the consensus on good palliative care is in a general sense, but in particular cases, it's never so simple, right? So we've defined palliative care. Let's get philosophical and look at what is good. Because sometimes we assume we know, and we may not. We may need to really think about it and talk about it more. I put down here, thanks to Brendan Lear for referring to this book in a previous Dossier talk, which I then followed up on and started reading, and it's really a good book on this topic, very clear. Traditionally, as Richard Taylor says, philosophical ethics has tried to answer the question, what is good? The question is one about which everyone has an opinion. Indeed, virtually everyone, except the most thoughtful, assume that they know the answer, and that it is so obvious that they need not even give it thought. Philosophical ethics is not so simple. The question, what is good, is a frightfully difficult one, and it cannot be answered without forming a certain general conception of human nature. The emphasis there is mine. I'll talk about it in a second. The Socratic admonition, know thyself, is especially pertinent, for how can you know what is your ultimate good if you do not know what you are? The question, what is good, is certainly the most important question you can ask, for it comes to this. Each of us has one life to live, and that life can be, as it commonly is, wasted in the pursuit of specious goals, things that turn out to be worthless the moment they are possessed. Put it this way, there will come a day for each of us to die. So I do think Taylor's comment that appreciating the import of this question, what is good, necessitates us to have an idea of human nature. But I just wanted to say, and there's a debate about this in philosophical literature, that I don't think that means that you have to have a sort of totally well-described theoretical idea of human nature before you even approach the question. I mean, we learn about our nature and human nature in general through life, and through our feelings as well as our thoughts. And so that's part of the debate. And that also relates to the point that's down at the bottom in the parentheses about moral voluntarism versus moral rationalism, which if you're interested in, this is a great book to look at, as well as its critiques in the literature, but I don't want to get sidetracked on that for today. Okay. I do think it's worth it looking a bit more at this question of specious goals in this age of distraction, which does impact our work, can impact our work, especially when technology is so important in healthcare these days. It is important that we don't get distracted by the technology. A very interesting recent article by Chris Hayes in The Atlantic, "You're Being Alienated from Your Own Attention." I recommend that if you're interested. And then that's really a excerpt or a summary from his longer book that just came out recently too, called "The Siren's Call: How Attention Became the World's Most Endangered Resource." Another one in The Atlantic recently, which I just happened to stumble upon, "You're Going to Die. That's a Good Thing." Also very worth reading and quite brief, in fact. In terms of attending to our patients, I've mentioned this book before, no doubt, in previous talks. So I'll mention it again because it's really excellent on being present, just sitting down and listening without assumption, and how to help our patients through simply being present. And we see the hands there again, which are so important. So good palliative care is what? Now, I've kind of highlighted the extremes of opinion here in order to make the dynamics of the question more apparent. I don't think many people adhere to these extremes, although some definitely do. Some people think good palliative care is no palliative care because good and ethical medicine is aggressive treatment until death. Some people think good palliative care is no palliative care because medicine is terrible at alleviating suffering, and therefore euthanasia is the best option. Some people think palliative care should monopolize all of healthcare because aggressive medicine causes more harm than good overall. And for an interesting perspective from this point of view, you could see the book Medical Nihilism by Jacob Stegenga. He's arguing more against medicine than for palliative care, but it is an interesting take on medical nihilism. One about which I don't agree, but it's very interesting. And he's not sort of a quack. He's written a book as well that's considered to be one of the main textbooks, from what I can gather, on medical philosophy of medicine these days. Palliative care and curative care are both important parts of good health care, and we in palliative care need to do our best to ensure we are delivering thoughtful, effective care within the context. That's the more balanced approach, and that's my take on it. In other words, good palliative care, like all good health care, requires balance. Which raises this interesting idea of the doctrine of the mean. And I'm just presenting this here in order to highlight that this idea of balance, a balanced approach, is not a new thing in medicine or in ethics. Doctrine of the mean is core doctrine of Confucianism. You can see it in one of the 4 books, Zongyang, pardon me, by ZZ, which I think means the doctrine of the mean. It's also fundamental in much of the work on good practice in Plato, Aristotle, Hippocrates, Galen, the golden mean. It emphasizes, as Wikipedia says and many other sources, moderation, rectitude, objectivity, sincerity, honesty, and propriety. The guiding principle is that one should never act in excess. This is an interesting book that I found, published in Edmonton, actually, Method, Medicine, and Metaphysics, on this idea of the doctrine of the mean and medical practice in early Greek medicine. Okay. That's all great and interesting and important to reflect upon, but I don't know that we too often go around thinking in our everyday practice at the bedside, what would Aristotle do? Maybe some of us do, I mean, which is great. But let's look at sort of more everyday sides of the question. Cicely Saunders, considered to be one of, if not the founder of modern palliative care, simply says one must meet patients where they are, not where we think they should be. And that's a fundamental tenet of good palliative care in her mind. This was quoted in Balfour Mount's autobiography, who's Balfour Mount's a physician still alive, from Montreal, who was a urologist, but went into palliative care and is considered really one of the founders of Canadian palliative care. And it's a really excellent book if you get a chance to look at it. It's quite long. But we need to keep in mind, and this is my emphasis here, we must meet patients where they are, but where patients are often depends on what quality of information or what information we give them. So whether or not they are making well-founded decisions depends often on the quality of the information we give them. Okay, so how to proceed from here? Celeste, who knows everything, as a one-year-old granddaughter of mine, says you just do your planks, which means get back to the concrete reality. And so let's look at a case. Isn't she cute? If you want, I can just stop and show pictures of my grandkids. No, let's look at the case. This is important. Mrs. Jones is a 66-year-old woman who is widowed and lives alone. She was diagnosed with ovarian cancer 3 years ago. She had a total hysterectomy and bilateral salpingo oophorectomy, followed by multiple courses of chemotherapy, cisplatin mostly, and targeted therapies, newer biologics. Based on CT scans and a C125 level, she has been considered to be in remission for the last 6 months. She remains on maintenance targeted therapy, olaparib in this case. Today, she presents to the ER of a large tertiary care hospital with new colicky abdominal pain, bloating, and 6 out of 10 nausea and vomiting. Her last bowel movement was 2 days ago. Her frequent emesis now consists of virtually clear fluid. She's cognitively lucid and confirms that her goals of care are C1. That is, that she desires only interventions that may improve comfort. She states, I just want to get this pain and vomiting settled so I can get home to see my grandchildren who are arriving from Nova Scotia in 3 days. Some questions so far about Mrs. Jones' situation. Does she understand or desire her current goals of care and designation? It seems she does. Why is this important for palliative care to know? It's important because often people have designated goals of care on their file, but they've actually never really had a good conversation about it. In this case, Mrs. Jones has. Has she had standard of care treatment for her underlying disease? Answer seems to be yes. She's been treated by gynae surgeons and oncologists and continues to be followed by oncology. Why is this important for palliative care to know? Because if she hasn't and she's interested in it, obviously her disease status and treatment options may be different than she thinks, and different than possibly we think if we're not specialists in her disease. Has she received recent cancer treatment? Yes, she is on ongoing targeted maintenance therapy. And this is important for palliative care to know in terms of side effects, possible survival time. Obviously, we just need to know what our patients are on to do our best for them. Carrying on with Mrs. Jones' situation, she's refused a nasogastric tube. She's given an ondansetron 4 milligrams subcutaneously for her nausea to minimal effect. That's every 8 hours. She continues on this low dose of morphine and laxative regimen that she has been on for the last 10 months. She agrees to any physical exams, imaging, and labs that may help manage her symptoms. Physical exam reveals a distended, tender abdomen, including rebound tenderness, high-pitched bowel sounds. Her abdomen is tympanic on percussion. Her mouth is dry. She has no signs of thrush. Her labs are normal other than the possibility of mild dehydration. Her abdominal X-ray shows multiple air fluid levels in the colon, suggestive of bowel obstruction. She agrees to a CT abdomen, but this cannot be done until tomorrow. Family medicine agrees to admit her. Is this good palliative care so far? It's reasonable. We can discuss this further in question time, which I hope there'll be plenty of time, and hopefully plenty of questions and comments. Would the plan of care be different if she were not in a large, big city hospital? Well, that's an important question. What is available and what she wants may be different if she's in a smaller center. And what she wants about what's available, especially if she doesn't want to be transported out of her smaller center. But she is in a large center here. What should we do in the meantime? Example, should we begin symptomatic management of bowel obstruction while waiting for further delineation of the situation from imaging, for example? It is decided to proceed with management of bowel obstruction. Dan's trying to stop. It's not helping. Dexamethasone, 8 milligrams subcutaneous twice a day is ordered at 8 and 1400, not too late in the day, so it doesn't wake her up. And that's to try and shrink any edema associated with the offending tumor that's causing the bowel obstruction. For nausea and emesis, haloperidol, 1 milligram subcutaneous every 8 hours around the clock and every 2 hours if needed is ordered. Palliative care often finds that this dopamine blocker is helpful in these situations for alleviating nausea, but it doesn't push the bowel and therefore exacerbate reverse peristalsis and associated nausea and vomiting. Morphine is switched to subcutaneous because you can't keep it down orally. Laxatives are to be continued as possible. Mrs. Jones has a much better night. She has a small bowel movement and is able to take a bowl of chicken soup and then sleep for 6 hours. The CT is done in the morning and reveals extensive tumor recurrence in the peritoneum and an extraluminal compression in the ascending colon causing obstruction. Possibly partial given the present clinical picture is the comment. The following day, the palliative care MD suggests switching her antiemetic to metoclopramide 10 milligrams every 4 hours, which is a dopamine blocker with promotility action. So it does push the upper bowel. It explains this as an attempt to get your bowel moving again. She agrees to try this while emphasizing that she needs to get home within the next 2 days. And this so far is very conventional practice. It varies from physician to physician, but it's not like off the wall practice, okay? Is this good palliative care so far? Seems to me it's reasonable. You can always debate about the timing of things, and perhaps we'll do that in a minute. The next morning, Mrs. Jones' nausea, vomiting, and abdominal pain are much worse. She complains in frustration, "I thought this was going to help my symptoms." The palliative team stops the metoclopramide, resumes the haloperidol, and suggests she can likely get home tomorrow, but come back if things get worse again. That night, Mrs. Jones has a high fever. Let's just stop for a minute. So the implication is that the prokinetic, the promotility agent, the Maxran, was pushing the bowel too soon, or maybe there never would have been an opportunity when the obstruction settled down enough to for the prokinetic agent to overcome the obstruction and salvage bowel function, so to speak. Nevertheless, it's not an unreasonable thing to attempt given the way she had responded. In any case, it's backfiring now, it would seem. So palliative care goes back to Haldol, which is a good antiemetic in this situation, but doesn't push the bowel. That night, unfortunately, Mrs. Jones has a high fever, low blood pressure, and a very tender abdomen. The attending team feels she has developed septicemia from a perforated bowel. This is not common, but does happen and can happen in the setting of prokinetics, particularly in bowel obstruction. Her morphine and haloperidol are increased, and she dies in her sleep at 06:35 hours. So not a wonderful outcome in this situation, but these things happen. Was this good palliative care? That's hard to know unless we're there and actually witnessing the discussions. On the face of it, what was done was not unreasonable. The timing may have been rushed. It's hard to say. Would medical nihilism have been a better approach? Should we just sedate away all symptoms and not even bother to find causes, let alone treat them in palliative care? And to be honest about my bias, I tend to be one who's all for reversing what can be reversed. Although I do sometimes wonder if I'm overly optimistic. So this is at times a very legitimate question for sure. What is the golden mean for people like Mrs. Jones? Is it even relevant? Was the palliative MD, so what is a good balance of care in this setting, and is it even achievable? Was the palliative MD overconfident about the metoclopramide? Maybe, but it's not like he was practicing off-the-wall medicine there. It's very common to do that. Hindsight is 20/20, as we say. This is a little YouTube. My presentation is fairly short today because I'm hoping for lots of questions. In any case, this is a little YouTube about certainty. It's from this film. I can't remember what it's called now. In any case, a recent film about the papal elections. So it's not about medicine, but I do like this little reflection by Ray Fiennes, the actor here, on certainty. My wife is in the room and just reminded me the name of the film is Conclave. Here's a little clip, just a short one. Do it here. Oh, just a second. Oh, sorry. There we go. Certainty. Certainty is the great enemy of you. Certainty is the enemy. Okay, so that's just a reflection on the downside of certainty, which I think is important to remember in medicine. Now I got to get back to my slides here. Sorry about that, Michael.
No problem. And Gary, just to let you know, I think the audio came across as a little bit quiet and then it suddenly cut out through the video. So we might have some issues with the video
Okay.
sharing.
Okay, that's fine. I'll just summarize what that is. Now I need to get back to my slides. Just a second. Oh, here we go. Are you seeing that now? Yeah.
Yeah, we can see it well.
Thank you. Okay, so yeah, Michael's just informed me, unfortunately, the audio didn't work that well. So basically, this is Ray Fiennes as Cardinal Lawrence, I think his name is, just sort of cautioning his colleagues during the papal election. It's not a spoiler, I don't think. It's fairly early in the film, that being overly certain about things is folly. And that's the case in medicine too, of course. That's all I'm trying to say here. Which leads us to a fairly obvious point, but one we often forget, about the need for humility in our work. And to be honest, this case I presented is one where I would have done exactly that. And I'm usually all for trying to salvage what we can of normal function. But sometimes if we're too aggressive about that, we cause more suffering. We need to be very cautious and humble about that. So this is a really excellent article from 20 years ago, almost, in the Hastings Center report by a pediatrician reflecting very honestly about his work with spina bifida patients. So John Freeman says, I realize the depths of the biases and prejudices that continue to underlie my personal ethics and my decision-making. I realized how limited is my own view of other people's quality of life. And he's saying this in response to feedback he's gotten from patients who weren't as positive about the way things had transpired for them as he was. And he realized that he was making a lot of assumptions. So in summary, and then there'll be plenty of time for discussion, which is good. Hopefully you guys have lots of comments and questions or comments for me to think about. What is good palliative care? Some palliative care must be patient. Good palliative care must be patient and family focused. Our patient today wasn't with us long enough for the family to come to the hospital, but clearly family support will be needed for his son, daughter-in-law, and grandchildren. Who and how should this support be given? Patients and family are dependent on good information from health professionals in order to make informed decisions. How should this information be framed and delivered? How should health professionals approach situations where patients wish them to make all treatment decisions? This still happens, not that often, but occasionally it does. A balanced approach to the risks, benefits of any interventions makes sense and has a long and venerable tradition in medicine, but how is the golden mean achieved in day-to-day practice? And that will clearly vary from patient to patient. We can't have just sort of abstract assumptions about that. Confidence is good. Certainty is often not good. Humility based in truth is always good. That's my little philosophical reflection at the end. And I don't know if this is going to work. Let's try it. This is just a short clip from Leonard Cohen, whom I love. Are you hearing that, Michael?
The volume's unfortunately, I think,
I don't know. It's a good song.
Relatively quiet compared to your voice. So you could
Okay.
sing it, Gary.
I could sing it. Yeah. It's an idea. I'll bring my guitar next time. No, it's just Leonard reflecting on death and dying, basically. He's good on topics like that. Okay, so let me just leave it at that. And we have plenty of time for questions, in fact, because that's the end of my formal talk. I hope there are questions, because in an attempt to not be pressed at the end, as I often am, I may have been a little shorter than I thought. In any case, there we are. Hope you have some comments and questions.